sources of authority, because I think that's a really important question to address. And so I might tell a story in relation to that at the end. Guy kindly sought out my views about health literacy, and my immediate response was to think that when we're talking about health literacy, we have to be really careful not to be part of a health enterprise that keeps putting responsibility onto individuals to deal with things that are outside their control. And it made me think about what are the complementary requirements of health professionals in order for the endeavour of increasing the health literacy of the community to be the most productive exercise that it can be. And it seemed that there were 3 areas of competence or literacy that are required of us as health professionals in order to create the kind of environment in which it's worthwhile working to increase health literacy. One is our literacy or competence about the social. A second is our competence with structure and structures, and we've heard about that already today in some of the stuff that Sam talked about. And the third is what do we know and understand about commercial determinants of health, and the overlap in my field almost complete between the commercial and the scientific. There's very little scientific endeavor in psychiatry that isn't commercially motivated. So first, just to take the, okay, that's not possible for anybody to see, but what I'm thinking about here is somebody who has in mind a health literacy intervention where a child is newly diagnosed with diabetes. And what do we need to know about the situation before we embark on that worthwhile endeavour? We need to know what the social circumstances are for that particular individual. So in this case, for those of you not familiar with this semiotic system, Jaden is the boy with diabetes. He's a 9-year-old. He's got a little sister. They live in their own home. They've got a manageable mortgage, a stay-at-home mum, a father who runs his own business. There's a bit of illness in the family, but that seems to be offset by the fact that there's a nurse living in the household with the grandmother. So you can feel that this is a family that can organise itself to support the care for Jaden's newly diagnosed diabetes. And so we would be able to have reasonable expectations of health compliance. If we look at the same sort of situation, the same people in the family, we can see that the expectations of this family are going to be very different. Now, my contention would be that too often doctors and other health professionals don't know whether Jaden is living in this kind of family or in the other kind of family, and that our interventions aimed towards informed consent and health literacy don't take account of the social circumstances in which people live. We also are at risk of not taking into account the structural determinants of health, the quality of neighbourhood and society, which determines the parameters within which health develops and whether we thrive or not. The protective institutions that ameliorate some of the effects of living in poverty and disadvantage. So when we're talking about literacy, we have to bear in mind that up to 25% of people lack general literacy skills. And so unless and until we address that, we're not going to succeed with specific health literacy interventions. And then our health services come in right down the hierarchy at the corrective level. And so enhancing health literacy is only going to be effective if our approaches are taking account of the structural requirements. And just to recommend Fran Baum's book, Governing for Health, which I think is essential reading before we start talking about our individual interventions. So if we turn to the commercial determinants of health, what do you think is the answer to this question? What do you think the percentage of people in our community who think that antidepressants work by correcting a chemical imbalance in the brain? Yeah, 93%. Now, this is not misinformation in the sense that it comes from fringe websites. This is something that medical professionals tell people, and it's a complete concoction, and it's a concoction of the marketing department of pharmaceutical companies, who found that drugs that affected serotonin and other neurotransmitters seem to have an effect on people's mood. And so they retrofitted that finding, or they retrofitted the science to that finding by saying, well, if we're changing chemical balance, there must have been an imbalance in the first place that we're correcting. So in fact, the reality is that antidepressants cause a chemical imbalance. They don't correct one. Now, how do you go when you try to correct misinformation about this? So Brett Deakin put forward a study where what they were going to do was to take the current kind of informed consent form that's required to get consent for somebody to enter into an antidepressant trial, and also to design what they thought was properly informed consent. And so they went to these 14 parameters that have been defined to that you need to cover in order to give people the information they need to make an informed decision about whether they should take an antidepressant. And they went to the ethics committee and they said, we want to compare people's response to the standard informed consent, which just says, we think these drugs are a terribly good idea and you should take them, to properly informed consent that properly outlines what the harms and benefits might be of taking the drug. And the response of the ethics committee was to say, you can't have our approval to conduct that study because what you're describing as the properly informed consent form will scare too many people and stop them from taking the drugs. So let me tell you a story about where people might go for their information about ADHD. Just recently, there have been ADHD guidelines published. They're described as ADHD evidence-based guidelines. And this appears to have got over the community uncertainty about whether ADHD, how it should be diagnosed and how it should be treated. Now, when you look at the evidence-based guidelines, they make 113 recommendations. And of those recommendations, there's evidence available to support 12 of them. And of those 12, only 3 have other than very low quality evidence to support them. So that is, what are marketed as evidence-based guidelines for ADHD are, if you look at the fine print or even the medium-sized print, opinion-based guidelines. And when you look at who's produced the guidelines, they're produced by the Australian Association of ADHD Professionals, an organisation that's sponsored by the pharmaceutical industry, that is led by people with entanglement with industry, and the guideline group was composed of people with significant conflicts of interest. So a group of us made a complaint to the NHMRC, who had approved these guidelines, saying the guidelines they're not actually evidence-based. they're opinion-based. Now, the response from the NHMRC was fascinating because they basically told us that the guideline group had followed the appropriate grade guideline development methodology. That is, they had appropriately sought evidence for all of their recommendations, and having found that there was no evidence, they were then at liberty to provide the recommendations anyway because they'd followed the methodology. And also that we had no business making complaints about it because there'd been a consultation period and we'd missed the boat. And so science is only what is, scientific endeavor obviously is about wanting to, or it should be about wanting to find fault with your ideas. And if people come up with faults about your ideas, you should really be prepared to listen to them whenever they come up. But that's not the way that the NHMRC, our leading scientific health research body in Australia, sees things. And so what are we seeing? I think what we're seeing is a reaction, and a long-term now reaction, to elitism in science and in medicine in particular. And so how do you solve the problem of elite individuals thinking that they know best, like the doctors who think they do a really good job of doing end-of-life stuff? How do you solve that problem? Well, I've got an idea, let's put in a manager. And so what we have is the tension between all of the harms that are done by elitism and the harms that are done by managerialism. And I think the ADHD guidelines example tells you what happens when managerialism takes over. I'm not pretending there aren't problems when elitism is dominant, but the idea that that following procedure and methodology gives you an authority that's misplaced scientifically is, I think, really problematic. So how does that relate back to health literacy? Well, I think the way in which it relates back is that what are we going to be literate about? What's the content of that literacy? And I think that we doctors, those of us in the most powerful positions within the health system, have to worry much more about the quality of information that is available to the most literate, active, agentive patients, let alone those who lack those qualities, and take more responsibility for looking at the structural and social issues that stand in the way of best health for our patients. Thank you.